Good afternoon. My name is Katie Cook. I am the Telehealth Project Manager for Adirondack Health Institute. Thank you for joining us on this Monday afternoon for the Medicare Calendar Year 2019 Telehealth Changes webinar. A few housekeeping items to get started. The webinar will be recorded for future access, and the slide deck will be sent out later this week. All of your phones and/or computer microphones have been muted for this webinar. We will be taking questions through the Q&A box on your GoToWebinar dashboard throughout the session. Keep in mind that we will not be answering questions until the end of the webinar. So please keep your questions to the Q&A box and keep them as general as possible. If you have a question specific to your organization, it is best directed to my email on the screen, kcook@ahihealth.org. A quick disclaimer that any information provided on today's webinar is not to be regarded as legal advice. It is purely for informational purposes. Always consult with your legal counsel first. Adirondack Health Institute has made every attempt to ensure the accuracy and reliability of the information provided in this webinar. However, the information is provided as is without warranty of any kind. So today we're going to be covering the following topics. I want to first level set with everyone on the current state of Medicare's telehealth reimbursement policies. This will help shape the landscape and paint a nice positive picture for the changes that are being implemented for January 1st, 2019. We'll then go into some information on usage trends of telehealth for Medicare and how this will hopefully change with new proposed codes and policy. Identify existing barriers and reasons for slow adoption. And then the bulk of today's presentation will be covering the Physician Fee Schedule changes for 2019, as well as changes for federally qualified health centers, rural health clinics, and Medicare Advantage plans. So when looking at the current state of Medicare telehealth reimbursement, the telehealth statutory policy for Medicare has been limited and has not changed much in recent years. It started with the Balanced Budget Act of 1997. This act put forth that Medicare beneficiaries in rural areas called Health Professional Shortage Areas, or HPSAs for short, could receive care via telehealth. 3 years later, in 2000, the Benefits Improvement and Protection Act expanded Medicare beneficiaries to access telehealth in non-metropolitan statistical areas, or MSAs, and expanded eligible services for telehealth reimbursement. Since that time frame, various changes have been made administratively, including an increase in the number of codes reimbursed, which changes every year with the Physician Fee Schedule updates, and inclusion of chronic care management codes. So as of today, only live two-way audiovisual connections are reimbursed through Medicare. Store and forward technology, or asynchronous visits, are only reimbursed in Alaska and Hawaii demonstration pilots. And lastly, only certain providers on this list are eligible for reimbursement. This includes physicians. Psychiatrists are looped in as physicians, mid-levels, nurse midwives, clinical nurse specialists, certified registered nurse anesthetists, psychologists and social workers, and registered dietitians or nutrition professionals. If you do not see your provider type on this list, such as a therapist, physical therapist, licensed mental health counselor, social worker, those providers cannot bill telehealth services under Medicare, only the ones on this list. Additionally, as we've discussed, reimbursement at originating sites where the patient is located is limited to rural areas. So your HPSAs, your non-MSAs, or your demonstration pilots for store and forward. Eligible patient sites in those rural areas can include a physician's private practice, a hospital, a critical access hospital, rural health clinic, federally qualified health center, hospital-based or critical access hospital-based renal dialysis centers, including their satellites, skilled nursing facilities, and community mental health centers. So you may be wondering, how would I ever know if the area that my facility is located in qualifies for telehealth reimbursement. Am I rural or am I not rural? Thankfully, HRSA has a website that makes this very easy to find out. If you simply Google Medicare Telehealth Eligibility Analyzer and you find the website, it will allow you to input the address of your originating site, and it will immediately tell you if you're located in a HIPSA or non-MSA. It is a HRSA website, data.hrsa.gov, and if you go to the Tools section, you will be able to find this eligibility analyzer. So usage trends among telehealth. Telehealth services that are billed and have been audited show that telehealth has been widely underutilized by the Medicare population. An analysis of Medicare fee-for-service data for 2016 found that almost 90,000 beneficiaries utilized just over 275,000 telehealth services. Now, that is still a very large number, but this represents 1/4 of 1% of the more than 35 million fee-for-service Medicare beneficiaries. So if only 1% of Medicare's face-to-face encounters were instead provided by telehealth, it would result in a 13-fold increase in telehealth delivery of healthcare within the program. The most common services that were billed were office or other outpatient visits, individual psychotherapy, and follow-up with patients in nursing facilities. KPMG and the NORC did an exploratory analysis in 2015 and identified 19 high-volume services that could be delivered via telehealth if policies and coverage rules were expanded or changed. Keep in mind that these examples are provided for illustration purposes only and do not reflect recommendations for specific changes to current Medicare telehealth coverage. Some examples included varying levels of emergency department visits, new patient office or other outpatient visits, and varying levels of therapeutic activities or exercise between patient and provider. Some barriers to expansion of Medicare telehealth services. So current Medicare payment policies, as we have discussed, are limited to geographic and practice settings where the patient needs to be located for the provider to be paid. They have to be rural. This stems from Section 1834M of the Social Security Act, which prohibits Medicare payment for telehealth services to patients not located at the aforementioned originating sites. Section 1834M limits the types of practitioners as well as limits the originating sites to be located in rural areas. As we go throughout this webinar, I'm going to refer back to the 1834M regulations quite often, noting whether or not codes are subject or not subject to this particular aspect of the Social Security Act. It would take an act of Congress to change the 1834M regulations, so this is not something that CMS has the statutory authority to do. So now on to the good stuff, the positive changes that are happening beginning January 1st of 2019. So we're only a few weeks away from these changes being in effect. So keep in mind that the content on this page is telehealth policy only for originating sites. So all the information on this slide that I'm speaking to applies to where the patient is located. So per the recently passed Bipartisan Budget Act of 2018, renal dialysis facilities, hospital-based or critical access hospital-based renal dialysis centers, and the patient's home will be allowable originating sites for end-stage renal disease services only. An in-person visit is required once a month for the first 3 months of clinical assessments and once every 3 months thereafter. The geographic restrictions, those 1834M restrictions, will be waived in this case, but none of these sites will be eligible for a facility fee. So when I say the geographic restrictions will be waived, that means that renal dialysis facilities or patients in more urban areas will be able to access telehealth services for end-stage renal disease services. Next up, telestroke services have characteristically been limited considering 80% of strokes happen in the Medicare population, but going forward after January 1st, acute stroke services via telehealth may take place in currently eligible originating sites, so the list we talked about a few slides ago, and mobile stroke units, or any location deemed appropriate by the Secretary. For stroke services, the home is excluded in this case, but the geographic restrictions will be waived. A new modifier has been created for acute stroke services via telehealth. That modifier will be GO. You would append that to the HCPCS code or CPT code. We'll talk about what those particular acronyms mean later in the presentation. The rates for telestroke codes will range from $101 for G0425, which is the code for a telehealth consultation in the emergency department or initial inpatient up to 30 minutes, all the way up to $213 for G0508, which is the code once a patient is in critical care for a telehealth consultation, 60 minutes communicating with the patient and providers via telehealth. Keep in mind that the types of services and providers eligible to be reimbursed for the above services has not changed. So each year, the U.S. Department of Health and Human Services considers submissions for new telehealth delivered services to be approved. Submissions are allowed from providers, advocacy organizations, and other interested parties. The decision to add new codes depends on whether the services fall into one of two categories, so a Category 1 or Category 2 code. So a Category 1 code are services that are similar to what's already offered, professional consultations, office visits, and office psychiatry services that are already on the list of telehealth services. Category 2 codes are services that are not similar to those on the current list of telehealth services. Reviews of these requests include an assessment of whether the service is accurately described by the corresponding CPT code when delivered via telehealth, and whether the use of technology to deliver this new service would produce a demonstrated clinical benefit to the patient. So for 2019, CMS has added 2 codes for telehealth policy only. Keep in mind that HCPCS stands for Healthcare Common Procedure Coding System, and CPT stands for Current Procedural Terminology. I know most of you on this call are aware of that, but I just want it to be said anyways. HCPCS codes are broken into 3 separate levels. Level 1 codes are your standard CPT codes and are numeric. Level 2 codes are the alphanumeric codes and include non-physician products, supplies, and procedures not included in CPT. And Level 3 codes are local codes developed by state Medicaid agencies, Medicare contractors, and private insurers. So the 2 codes that were added for telehealth policy only, meaning they are subject to 1834M rurality restrictions, meaning they are only reimbursable in rural HIPSAs and non-MSAs, are codes G0513 and G0514. They stand for prolonged preventive services beyond the typical service time of a primary procedure in the office or other outpatient setting requiring direct patient contact beyond the usual service. So the first 30 minutes is billed as G0513, and then there is an add-on code for each additional 30 minutes of G0514. All components of these codes can be furnished via interactive telecommunications technology. Adding these codes will make it administratively easier for practitioners who report these services in connection with a preventive service that is furnished via telehealth, as both the base code and the add-on code would be reported with the telehealth place of service code of 02. My research indicates that these codes will have a reimbursement rate of around $66 a piece. And a side note that the HCPCS code of Q3014, so that's your originating site facility fee code, the current reimbursement rate for 2018 for that particular code is $25.76. It's reassessed on an annual basis based on the Medicare Economic Index. For 2019, the Medicare Economic Index increase is 1.5%, meaning that code Q3014 will be reimbursed at $26.15. That's your standard originating site facility fee that a facility can get reimbursed for initiating the technology connection to a distant site. So now we're going to get into remote patient monitoring and chronic care management. This is not being labeled as a telehealth service for CMS. In January 2015, CMS created a new chronic care management code 99091, which provides for non-face-to-face consultation. This has opened up the possibility of receiving reimbursement for virtual asynchronous remote monitoring of chronic conditions. Since then, CMS has released several instructional documents on billing the chronic care management codes, added reimbursement for complex chronic care management, as well as 2 add-on codes. Additionally, SQHCs and RHCs are allowed to bill for chronic care management. CMS is recognizing the role that new communications technologies play in increasing patient engagement and reducing unnecessary costs and readmissions. These new rules articulate for the first time a firm distinction between Medicare Telehealth Services and RPM services. Additionally, in the final 2018 Physician Fee Schedule, CMS decided to unbundle code 99091, allowing providers to get reimbursed separately for time spent on collection and interpretation of health data generated remotely. By not defining these codes as a telehealth services, these services are not subject to the restrictions other telehealth services currently face, such as the 1834M geographic and location limitations and prohibitions on the use of asynchronous technology. So again, the codes that are up on the screen right now are not subject to the existing rurality restrictions. So these codes are CPT code 99453. So this is your remote monitoring code for the initial setup and patient education on the use of equipment. No physician work is required to bill this code. It's simply reimbursement for the practice expense associated with furnishing remote patient monitoring services. So an example of this code from a workflow perspective could be that a primary care physician identifies a patient, explains the remote patient monitoring program to the patient during an office visit. Clinic staff enter device information in, say, the vendor's back-end portal. They enter alerts and/or care plan, demographics, medications, parameters, etc. They then train the patient on the use of the device, and the patient begins using it. The reimbursement rate for this code appears to be between $19 and $21 per setup. Next up is CPT code 99454, which is essentially your device is supplied with daily recordings or programmed alerts, and you get billed each 30 days. So that's basically your staff monitoring the alerts on the back end that are coming from what the patient inputs into the device. No physician work is required to bill for this code either. It's simply the reimbursement for the practice expense associated with using this technology. So an example of workflow for this code could be that alert parameters are approved for the patient based on individual biometrics. Alert parameters are then put into the vendor backend portal, and clinic staff determine the need for the frequency of alerts and reviewing or tracking the data. Reimbursement for this code appears to be between $64 and $69 per patient per month. And lastly, we have CPT code 99457, which is Remote Physiologic Monitoring Treatment Management Services of 20 minutes or more from clinical staff, physician, or other qualified healthcare professional, time in a calendar month, requiring interactive communication with the patient or caregiver during that month. So notice that it says clinical staff or other qualified healthcare professionals. So that means your nursing staff could bill for this code. An example of workflow for this code means responding to alerts in a timely manner, calling patients with alerts and validating the accuracy of the alerts, instructing the patient on device usage and readings if the alert is not valid, and if the alert is valid, conducting an assessment and providing patient education, documenting each encounter, and escalating information to the medical provider to reach back out where necessary. This code appears to be reimbursed at a rate of $52 to $54 per person per month. Next up, we're going to go into community technology-based services. Again, these codes are also not subject to the 1834M rurality restrictions, just like the 3 codes I previously discussed. The following codes are services furnished remotely using communications technology and are not considered Medicare telehealth services. So we have our virtual check-in code, our store and forward code, and then our interprofessional internet consultation codes. So the virtual check-in code, which is HCPCS code G2012. This is your synchronous real-time virtual check-in with a patient lasting 5 to 10 minutes. It may be done over the telephone or over live video conferencing technology. It has to be a patient-initiated visit with an established patient, though. It cannot be a new patient to a new provider. The patient must have or provide verbal consent with each check-in and be aware that as a beneficiary, they may be financially liable for sharing the cost of these services. So that's something important to keep in mind, that the patient will still be liable for a copay or coinsurance or deductible when engaging in a virtual check-in service. This cannot be waived due to lack of statutory authority. The virtual check-in cannot originate from an E&M visit happening 7 days prior, nor can it result in the patient coming in for an E&M visit within 24 hours or the soonest available appointment. There is no frequency limit on the use of this code for 2019, but CMS will be monitoring utilization to see if a frequency limit needs to be placed. This service is meant to describe and account for the resources involved when the billing practitioner furnishes the virtual check-in. It appears that the reimbursement for this code will be $15 per visit. Note that when I say the resources involved when the billing practitioner furnishes the virtual check-in, meaning that only eligible Medicare providers from that list we talked about in the beginning can bill for this service. So basically, any practitioner on that list that can bill a normal E&M code can bill for this service. I can see this being especially useful for patients that have just a quick need to chat with their doctor, whether over the phone or video conferencing, to avoid having to travel to their local doctor's office for an in-person visit. This can certainly save a lot of opportunity cost, time, and resources on both the patient and provider side. Next up, we have the store and forward code. So this is code G2010, and it's remote evaluation of pre-recorded patient information. Asynchronous store and forward used to determine whether or not an office visit or other services is warranted. So this is a pre-recorded patient-generated video and or images. So again, the patient has to be sending in the video and or images to the provider. It has to be a patient-initiated visit, and the patient has to be established with the provider at hand. There must be verbal or written consent with each check-in, and of course, cost sharing is something to relay to the beneficiary or patient, letting them know that they may be responsible for some sort of copay, coinsurance, or deductible. There's no way to change that due to lack of statutory authority. Similar to the previously discussed virtual check-in code, this cannot originate from an E&M visit 7 days prior, nor result in an E&M visit within 24 hours or the soonest available appointment. There is no frequency limit on the use of this code, but utilization will be monitored. And interpretation and follow-up can be done through any method, which means that the provider can engage with the patient via phone call, audio-video communication, secure text messaging or email, or patient portal communication, so long as it's done within 24 hours. So a code like this, I think like teleretinopathy is a very common and popular store and forward technology. However, the images would need to be acquired and submitted by the patient directly. The code would need to be billed by the ophthalmologist, who would also be responsible for following up with the patient directly, and the images cannot result from a related E&M visit. Also, this code can be billed only for established patients, which is unlikely in the case of an ophthalmologist, and it's unlikely that a patient will be obtaining clear and accurate images for the diagnosis of diabetic retinopathy. So for that particular clinical specialty, I don't know if G2010 would be a good fit for this care delivery model and related services. Just an example. Next up, we have interprofessional internet consultations. All of these codes require verbal consent, cost sharing with the patient needs to be disclosed, and it can be done via the internet or phone. Again, only practitioners who are eligible to bill Medicare for E&M visits can bill these codes on this screen. So to start, we have CPT codes 99446 through 99449. These are your interprofessional telephone and internet assessment and management services provided by a consulting physician, including a verbal and written report to the patient's treating or requesting physician or other qualified healthcare professional. The 446 through 449 indicate the amount of time spent on medical consultative discussion and review. So it depends on the code, but the reimbursement rates will vary between $18 and $73 depending on how much time is spent between those two physicians talking about that assessment. Additionally, codes 99451 and 99452 have been put in place for additional interprofessional internet, telephone, and electronic health record referral service codes, 5 or more minutes of medical consultative time. Again, all codes require verbal consent. There is cost sharing that the beneficiary needs to be aware of, and they can be done via the internet or phone. So now I want to talk a little bit about how CMS is relaxing some of their reimbursement policies for opioids and substance use disorder. The SUPPORT Act, which stands for Substance Use Disorder Prevention that promotes opioid recovery and treatment, becomes effective July 1st, 2019. It requires CMS to adjust their reimbursement policy of telehealth for treating individuals with substance use disorders or a co-occurring mental health disorder. It removes the originating site geographic requirements for telehealth services after July 1st of 2019 for any existing Medicare telehealth originating site. And the exciting part about this act is that it adds the home as a permissible originating site. This act is currently in a 60-day period for the public to comment on the provisions of the interim final rule. Section 2005 of the SUPPORT Act does establish a new Medicare benefit category for opioid use disorder treatment services furnished by opioid treatment programs under Medicare Part B. This requires that opioid use disorder treatment services would include FDA-approved opioid agonist and antagonist treatment medications, the dispensing and administration of such medications if applicable, substance use disorder counseling, individual and group therapy, toxicology testing, and other services determined appropriate. Additionally, within 1 year, the DEA must have final regulations for a special telemedicine registration for practitioners to remotely prescribe Suboxone and buprenorphine through telehealth. Additionally, not on this slide, the VETS Act, which stands for Veterans eHealth and Telemedicine Support, was recently passed, which allows VA licensed clinicians to conduct telehealth visits from anywhere to anywhere with a single license, allowing them to cross state lines. So now we're going to discuss the changes for calendar year 2019 for federally qualified health centers and rural health clinics. So the previously mentioned virtual check-in and remote evaluation codes, G2012 and G2010, will be renamed as the HCPCS code G0071. So if you are on the line and you are from a federally qualified health center or rural health clinic, you would not be using the two G codes previously discussed. They've bundled it into G0071. Keep in mind that SQHCs and RHCs will not receive the prospective payment system rate for this code. This code, G0071, is set at the average of the national non-facility physician fee schedule payment rate for codes G2012 and G2010, and it will be updated annually. Similar to the provisions for the aforementioned G codes, the services do need to be furnished by an FQHC or RHC practitioner to a patient who has had a billable visit within the previous year, and the discussion or remote evaluation is not related to an E&M visit that occurred within the previous 7 days and does not lead to another E&M visit within 24 hours or the soonest available appointment. There must be at least 5 minutes of communication technology-based or remote evaluation services. There are also no frequency limitations for G0071, and cost sharing does apply. For rural health centers, coinsurance and deductibles apply, and for FQHC claims, only the beneficiary's coinsurance applies for code G0071. And lastly, and unfortunately, FQHCs and RHCs are not able to use the aforementioned interprofessional internet consultation codes. Additionally, comments were proposed citing that FQHCs and RHCs should be able to function as distance sites for telehealth. I have personally been asked this question many times as to why a federally qualified health center cannot function as a distance site and only as an originating site, or why can't they function as both. But per the 1834M Social Security Act regulations, these particular facilities can serve as telehealth originating sites only. While other components of the Social Security Act describe distant site telehealth services, FQHCs and RHCs are just not included. CMS does not have the authority to allow for FQHCs and RHCs to furnish distant site telehealth services. Therefore, for now, without an act of Congress in place, these facility types cannot bill as a distant site. And next up, we're going to talk about Medicare Advantage plans and some of the changes towards those. So beginning January 1st of 2020, Medicare Advantage plans will have the flexibility to add telehealth services as part of their core benefits. CMS is soliciting comments through the end of the year regarding if they should place any additional restrictions on benefits, such as service codes or specialty, and any additional requirements for providers. Medicare Advantage plans can decide what services will be offered so long as they're covered under Medicare Part B and meet certain requirements, which are listed below. It is not mandatory for these plans to offer to cover more services beyond what is required in fee-for-service. Patients who elect to receive the benefit may end up paying for it with higher premiums, additional co-pays, or from the plan's rebates. State laws regarding the practice of medicine would still apply. If the additional telehealth services are not covered under Part B, the Medicare Advantage plan may offer those services via telehealth under a supplemental plan. Additionally, as part of the Bipartisan Budget Act, all Medicare two-sided accountable care organizations will have the flexibility come January 1st, 2020 to use telehealth in urban areas and the patient's home. So what does this mean in terms of opportunities for those of you on the line? These new codes offer opportunities to expand or start new telehealth programs and is a true turning point for CMS in expanding their coverage of telehealth. For anybody who's been keeping a pulse on the regulatory landscape of telehealth in the last year, you'll note that there have been numerous acts that have been proposed or put into place or even passed to have both at a federal and state level expanded coverage of telehealth. So I'd say in several years that I've been in the telehealth world, this has been the most active in terms of expansion and access to more patients and providers for more services. So these new codes and their subsequent payments will improve economic and business models and will allow new programs to develop or existing ones to expand. So my advice to you is to be proactive and take advantage of these new payment mechanisms. I think over the next couple of years, we will continue to see momentum to relax some of the still existing 1834M restrictions. It's my personal hope that someday SUHCs and RHCs can function as distance sites. Medicare will expand their list of eligible practitioners, and we'll see some of those restrictions start to lift over time. And lastly, the shift to value-based care is only going to continue to drive these changes and these new payment models. So now we are going to go into our question and answer period. I will give you guys about a minute to submit any last-minute questions, and our moderator, Sarah Dubnasian, will be posing the questions, and I will do my best to answer them. Again, if I don't have the answer to a question, I will get back with you personally and follow up in whatever way that I can. So just hang tight 1 minute while we compile our questions.
All right, so the first question we had says, do codes 99453, 99454, and 99457 require patient copayment?
Yes, if I go back to that slide, let me see here. Give me 1 second. Actually, I don't believe so. If I'm remembering correctly in looking at the RPM codes, there was nothing in the regulatory language that stated there would be cost sharing to the patient. So I'm going to say, based on my research at this time, to my knowledge, no, there is not a cost sharing component to the RPM services.
Okay. And I know you mentioned for the G2010 code is updated annually, but do you have an approximate reimbursement amount for that code?
For G2010, yes, I apologize, I might have skipped that. So for G2010, which is your store and forward remote evaluation code, it looks like the reimbursement rate for that is going to be around $13 a visit.
Okay. I see somebody asked to re-show these slides. So what we're going to do is we're actually going to put this slide deck out, and Katie will mail it out or email it out in the next few days. So look for that, and you'll be able to see all the slides then. I have another one. What kind of devices reflect the 99453 to 99457 codes?
That's a great question. So that comment did come up when the comment period was open for these changes, and CMS's stance on that was that they were not going to call out any specific device or vendor. It's really up to the patient's primary care team and practice to determine what particular device type or vendor they'd like to go with. They did not stipulate any certain type of device or vendor for those codes.
I have someone asking if you could repeat the store and forward rules for teleretinopathy.
The store and forward rules for teleretinopathy, it wasn't necessarily rules for teleretinopathy. It was an example that I cited. So if you think about teleretinopathy, the common workflow for that is that a patient would go to their primary care physician for their standard office visit, and if they have a diagnosis of diabetes or the like, then they would be brought into a room where the facility has a teleretinopathy camera set up. They would have to, basically black out the room for 5 to 10 minutes to allow the patient's pupils to dilate. Then the nurse will take the image. It gets forwarded off to an ophthalmologist that is, either in the state or works with a vendor, or maybe they have a contracted arrangement with a local ophthalmologist. And then, the ophthalmologist does the read, reports back to the primary care physician, and lets the patient know the outcome. With G2010 being that it needs to be a patient-generated image, typically that's most often going to come out of a patient's home, and patients are not going to have access to the specialty cameras required to capture an accurate diabetic retinopathy exam. So I was merely citing this as an example of where teleretinopathy, while regarded as a store and forward asynchronous service, would not be a good clinical application for code G2010.
Okay, I just wanted to note, I see 2 hands raised, Iris and Marilyn. Iris, I do see that you have already asked a question in the questions box, so if that is your question, don't worry about it. And Marilyn, if you wanted to ask your question, please post it in the questions box that is part of the dashboard. The next question, all right, for Medicare Advantage, does the geographical restriction apply?
I believe the answer to that question is yes. There was nothing cited that I saw about the 1834M regulations not applying to Medicare Advantage plans. So it's my understanding that these plans will have the flexibility to add telehealth services, but that it will still be subject to the existing 1834M restrictions.
Okay. And then I have 2 more that I see. Is there any more information on how 99452 might work for the treating/referring of QHPs? For the same service, would 99451 be used by the consulting physician, and then would 99452 be used by the treating/referring? I'm going to move it over.
So going back to those codes, code 99452 is the telephone, internet, or electronic health record referral service provided by a treating physician or qualified healthcare professional. So that particular code is for the physician who's treating the patient, not the consultative physician. Code 99451 is a health record assessment and management service provided by the consultative physician, including a written report to the treating physician of the patient or other qualified healthcare professional. So it looks like 99452 is more related to the referral back to the treating physician, and code 99451 is the assessment by the consultative physician to the treating physician. I hope that answers that. Electra, if you need to reach out to me privately, please feel free to do so.
All right, and our last question is, how do they establish security for group therapy if the originating sites can be homes?
My answer to that would be that to establish a secure, HIPAA-compliant, encrypted connection for any sort of telehealth service in the patient's home, you would obviously use a video conferencing platform that allows that. I know several practices, both in New York and Vermont, are utilizing Zoom, which is a very popular, cost-effective, HIPAA-compliant, secure video conferencing platform, so long as you sign a business associates agreement. So as long as you're providing a direct link to that visit only to the patient, and the patient clicks on that link and is in that secure room, then you're going to be fine. As we start to see more relaxed regulations, we will definitely get some more questions about that, but I know that in New York and Vermont, some practices I'm working with are using Zoom without a problem. If people have other family in their homes walking around, that's on the patient to be in a secure room and the provider to instruct the patient on how to have a good quality, secure visit. If you have family walking around in your home or children, maybe you're not the best candidate for home telehealth, or maybe you need to go in a separate room, a bedroom or a home office to have that visit. You obviously wouldn't get on a video call with your provider with other people walking around. I would say that's relatively common sense, but again, it's definitely a consideration.
All right, and we did get one more question in. Could Medicare Advantage plans offer coverage beyond traditional Medicare? Choose to allow patients to receive telepsychology to the home or outside of the geographic restriction?
Again, with Medicare Advantage plans, all it said was that they'll have the flexibility to add telehealth services as part of their core benefits. What each plan chooses to do and how they choose to offer it is up to the plan. That's not a question I could really answer accurately. It's just going to depend on the plan.
Okay. And I think that is all of the questions that we have, and I don't see any in the chat or anything else. So I think
Okay.
that's everything.
Well, thank you very much to everyone on the line for your thoughtful questions and for attending this webinar. I hope you found it beneficial. And again, my contact information is on the slide. If you have any follow-up questions or needed additional clarification, don't hesitate to reach out. I'll be sending out the recording and the slide deck later this week. And stay tuned for additional webinars in the spring that will be focusing on some updated Medicaid regulations and private payer updates for 2019. Have a wonderful Monday and a great week and a very happy holiday season. Thank you.